Welcome and thanks for pressing play. This episode of War Docs was made possible by a partnership with the Defense Strategies Institute's OpMed TV and was recorded at the 2024 Operational Medicine Symposium in San Antonio. These interviews focus on optimizing military medicine through the modernization and implementation of policies, education, training, research, and development. We also explore emerging technologies to enhance the health, strength, and survivability of warfighters. Welcome to this episode of War Docs in partnership with OpMed TV. Today we're going to speak with Dr. Darrin Clouse, who's a retired colonel in the Air Force. He's a vascular surgeon, and he's currently the chief of the University of Virginia Health Division of Vascular and Endovascular Surgery. Darrin, thanks for being on the show.
Thanks, Doug. Good to see you.
Good to see you. So tell us a little bit about your time in the military. You retired as a colonel, but how was that?
Yeah, you know, I used the Air Force to go to medical school, like many of us do, and finished medical school and came to Wilford Hall to do my general surgery training. Did that, and then went to Mass General in Boston to do my vascular fellowship. And then when I was at MGH, 9/11 happened. And so I came back to Wilford Hall as the vascular surgeon, and all of a sudden, these rumors started coming around that we were going to deploy and where things were going to happen. And so they did. And we spent time trying to figure out what an Air Force theater hospital looked like, how to deploy it, what to do with it. And so we did that and sent an Air Force theater hospital to Balad. Spent a couple of tours there, kept going, became the consultant to the Surgeon General, to Dr. Bruce Green, General Bruce Green, and for vascular surgery. And then Afghanistan happened, and we were just doing that. And so I ended up just staying because we were writing about our wartime experience. We were really kind of looking at vascular injury, and our whole group was, taking endovascular therapies. We were packing a separate bag and putting it on our shoulder and taking it out there and using the C-arms on plywood floors and stuff like that, and actually developed a platform for endovascular technology. Then went out to UC Davis in Northern California and worked with the VA in Northern California and Travis Air Force Base and developed a heart, lung, and vascular center there, and then headed out of the military. So that was it in a nutshell. But it was a long and good career, and really, if it wasn't for Iraq and Afghanistan, I probably wouldn't have stayed for 20 years.
So in your career, you've had the opportunity to deploy multiple times. You were in the military for 20 plus years. Now you're in the civilian sector. How would you say that vascular injuries are different as far as diagnosis and treatment in the military setting versus the civilian setting?
Yeah, that's a very interesting question. The diagnostics, at least in my mind as a vascular surgeon, don't change a whole lot. You still want to look at hard and soft signs. You want to figure out if there is an injury, how much hemorrhage / ischemia you're working with. The difference is that in the military environment, it's not infrequent that you have multiple arterial injuries. The wounding mechanism is more often blast, with both penetration, blast soft tissue injury, and blunt vascular injury. So I think that when you think about military injuries, they're more extensive. There's usually more than one in military casualties. On the civilian side, it's more frequent, blunt motor vehicle crashes, motorcycle crashes. Occasionally it's a penetrating injury with, depending upon where you are, knives and guns. But those are very succinct individual injuries for the most part. In the military, it's very frequent that you've got multiple casualties coming in that have multiple injuries.
Is there a particular experience or a case that you recall that was challenging for you in your several deployments?
Yeah, I'd say probably the most challenging one I can remember off the top of my head. There was a blast injury that really had significant components of penetration to it that was abdominal in nature and pelvic in nature, and essentially a very devascularized and non-viable external iliac artery, external iliac vein, shunted them with actually small chest tubes, and that was an extremely difficult situation because there was multiple hollow viscous injuries. Trying to figure out how best to manage that guy was one of the biggest struggles I had when I was in a theater of war. And that was really again, due to the type and nature of wounding of a military injury compared to, a civilian type of motor vehicle crash or a singular penetrating injury.
So in vascular surgery, you said you did a lot of research and very interested in cutting edge technologies. Where are there unmet needs in vascular surgery or vascular injury repair diagnostics? Where are we going? What do we need?
Yeah, through some of the work that's been done by people that I've worked with in the military, we're getting a better understanding that tissue tolerance to levels of ischemia is probably shorter in time than we previously recognized, and so time to actual revascularization has become very, very important. Some of the work on temporary shunting in injuries, when we're able to actually identify the injury, get rid of as much clot as we can in the artery and put a temporary shunt in, reestablish flow. But that tissue tolerance, and depending upon blast and other types of soft tissue defects, can be really challenging to treat. And so one of the unmet needs that I think is highly important and would be a real game changer for vascular injury would be an off-the-shelf conduit that's resistant to infection and is easy to use. Right now we have PTFE or Gore-Tex and we have Dacron. Those are very infection prone. Putting them into large devitalized areas of tissue only leads to infection. And so I think that the need really is in conduit. Great saphenous vein, single piece great saphenous vein for many of these injuries is available, but it takes time to harvest. And a lot of times in military injuries, particularly the extremity injuries, lower extremity injuries, you may not have good vein to do these reconstructions. And so something off the shelf would be a game changer for vascular injury.
So where are we going in that? Are we regenerating growing blood vessels somewhere in a lab? Are we making cellular matrices? How are we dealing with that?
Yeah, a lot of people are working on regenerative medicine, but right now a company called Humacyte has developed a human acellular vessel, or HAV. And essentially what that does is it takes a polyglycolic lattice, it takes human aortic cells and they culture them on that lattice, and then they decellularize them to gain an extracellular matrix tube, and they're using that as a conduit in vascular injury. There's actually been a prospective trial in the United States, no real competitor, but a prospective trial looking at HAV and traumatic wounds, and that's actually before the FDA right now for a BLA, a biologics licensing application.
So how is that different from a shunt? This is something that would stay in after you put it to bridge whatever gap you're trying to bridge?
Absolutely. The purpose of the HAV is to essentially be a definitive reconstruction. And so you'd sew it in just like you sew in every other graft, whether it's vein or prosthetic. And it handles very much like a cross between great saphenous vein and cryo artery. So it's got good tension and good tissue structure to it. It's easy to sew, and it's meant to be a definitive reconstruction. And what happens is that extracellular matrix, which is consistent across mammalian species, gets infiltrated by circulating cells. It's actually been shown to develop an adventitia in muscle cells. Phenotypically, the circulating cells change into muscle cells and you get a media, and it gets lined by an intima and a pseudointima. And so the whole goal is that you would actually regenerate an artery, if you will, through that reconstruction.
How long does that process take? And does that matrix disappear over time as it becomes more, turning into like a real artery?
Yeah, the short answer is yes. We don't really know exactly how long that whole process takes. The process to make an HAV is about 8 weeks, and they come in 40 centimeter conduits. And so if there's a longer injury and you need to do something longer, you can sew two of them together, splice two of them together and do a longer segment reconstruction. But we don't really have a good handle on how long it takes for recirculating cells to infiltrate and for the extracellular matrix to kind of disappear, if you will. And the cells will obviously continue to turn over extracellular matrix.
Now, is this only used in the arteries, or can it be used in the venous system as well?
That's a great question. There's been some use in the venous system, but we don't really have as much experience as we do in the arteries.
And one of the concerns about the synthetic stuff is thrombogenicity. How does this compare to the synthetics, the Dacron, the PTFE stuff?
Yeah, the early information is that it's at least equivalent to PTFE and probably better. And as you might imagine, the biology of it, and when it's infiltrated by the cells and the development of the artery and the lining, the intima, that whole process, we really don't understand exactly when it's complete, like we mentioned before. And so that's really the moment when you lose that thrombogenicity, is when you have that lining. And so that can take some time. But from what we understand so far, it does seem that it's not as thrombogenic as something like a PTFE or a prosthetic graft.
So you mentioned one of the problems with synthetics is infection. How does this HAV technology decrease that incidence of infection, and how would that work?
Well, as you might imagine, the circulating or local bacteria that adhere to synthetics, because they are synthetic in a way that's abnormal, the extracellular matrix kind of prevents that because it's native mammalian tissue. And then you also have the infiltrating cells and neutrophils, as well as the other cells that come through and populate the extracellular matrix. So you actually end up with a defense against bacteria naturally within the extracellular matrix graft. And so that's kind of a nice feature, and probably is one of the reasons why it's less infection prone.
So tell me, where are we with this technology, this innovation, this acellular vessel? Is it still in the lab phase, or animal models? Are we using it in humans? I know you said it wasn't FDA approved, but where are we?
Yeah, right now there's a BLA before the FDA. There's a target date of adjudication in August. So theorizing that it gets approved by the FDA as a biologic for use, then every trauma center in the country would be able to use HAV as an arterial reconstructive conduit for injury.
So now, I got a chance to see your presentation this morning at the symposium, and you were talking about this being utilized in the war in Ukraine. Can you kind of tell us a little bit about what's happening there and how is it being used?
Yeah, it was an amazing process. Humacyte and the FDA and the US regulatory system got together. Ukrainian surgeons actually asked Humacyte if they could have some HAV for some of the injuries in the Ukraine. That process was expedited. Humacyte was able to supply some conduit in Ukraine. They used it in 18 patients. There's been a report in Lancet last year of 13 of those patients. There's been limb salvage, there's been continued patency, and people have healed. There's been use of HAV in patients that have had to have synthetic grafts taken out due to thrombosis and infection, and those HAV grafts have performed well in those situations. So hopeful that here sometime late summer we'll have more news and be able to use the HAV, and it'll be more available to everyone.
What is the follow-up that's required for somebody who has that placed for an arterial injury? How do you follow them to make sure that it's not having complications?
Generally, we do the same thing for any type of graft in vascular surgery. We follow them with duplex ultrasound and with non-invasive tests of the blood pressures in their legs to confirm that the graft is doing what it's supposed to do. We do that usually sometime between 3 and 6 months after implantation, and then 6 months for a year or two, and then usually just annual follow-up with an ultrasound and those blood pressures in the legs.
Where would you see the use of this on the battlefield? You know, a lot of times we talk about damage control surgery. At the Roll 2, we have surgeons who are very capable, but the goal is to get patients out of there kind of as quickly as we can. Where do you see this acellular vessel fitting into the roles of care? Is it a Roll 2 thing, a Roll 3 thing? Is it in Germany? When do we put this in and how?
I think a lot of that's going to depend on what the future of warfare looks like, particularly medical care during war. We just heard this morning too about how things are being restructured in the Air Force in particular regarding types of and locations of care. And so I think that really the place that you can do a definitive vascular reconstruction is where HAV would have the most effect. I still think that Roll 2s are going to do damage control. They're going to do local wound exploration, arterial exploration, thrombectomy, and placement of a shunt. I think that in the proper hands and in the proper forward location, a Roll 2 might be able to use HAV as a conduit and do a reconstruction, but I still think it's probably going to be more so in that Level 3, Level 4 area where reconstructions can occur in a more definitive way and with resources available.
So you mentioned earlier that it takes 8 weeks to come up with one of these vessels. What's going on to make that process shorter, and is there any newer technology that can make these mass produced at a lower cost?
To be honest, I don't really know, but I know that Humacyte is investigating and looking at that and trying to figure out what their production methodology is going to be and how they're going to respond when HAV is approved. And so all that is occurring right now, but I don't really have any good insight into it. It's a focus.
So we talked about regenerative medicine a little bit. I mean, do you see that future where there's going to be lab-grown vessels that can replace really anything that comes out of the human body?
Yeah, I mean, that would be the ideal, I think. It's amazing. Technology just seems to be progressing at such a rapid pace. The stuff that we didn't really think much about when we were in the military is now becoming stuff that we talk about all the time as just what's happening in research and development. I do think that probably in the next couple of decades, you're going to see a bioengineered vein or a bioengineered artery for reconstruction. And this may be a way to actually do that and make it applicable across the board to many people, where you lose you take away the immunogenicity, yet you're able to actually use the patient's own circulating cells to regenerate.
That is kind of cool, and it seems like that would have been Jetson era space age stuff, but people are looking at that right now.
Yeah.
So you had a distinguished career in the Air Force military medicine system, and we've got some younger viewers and listeners who tune in. What advice would you give to maybe someone in high school or college who's thinking about military medicine as a possible career path, whether it be as a medic, corpsman, nurse, doctor, whatever? What advice would you give them?
I think the main advice is do it. The things that I learned in the military, I had no idea that I would learn. The concept of teamwork, the concept of on such a deep and sophisticated level, the concept of how important it is to think and to identify gaps and needs that can challenge people in austere environments. Those types of things are really powerful. And I think that if you're thinking about doing military medicine, you should absolutely do it, because the things that you learn, the things you're exposed to, such as the conference here with all the technologies, it will stimulate you and it will create a situation for you that probably you don't even understand right now.
We've been speaking with Dr. Darrin Clouse on this combined project with WarDocs and OpMed TV. Darrin, thanks for talking to us.
Thanks so much, Doug.
It's good to see you again.
Good to see you too.
It's great.
Thank you.
Thank you for tuning in to this special episode of WarDocs, made possible by a partnership with the Defense Strategies Institute's OpMed TV. To stay connected with Team WarDocs, visit our website at wardocspodcast.com. Follow us on social media for updates and subscribe to our WarDocs YouTube channel for more engaging content. Your support helps us continue to document the experiences and contributions of military medicine professionals as we honor the legacy and preserve the history of military medicine for the next generation.